a localized, mounting physical tension, an escalating urge that demands immediate physical release, overriding rational thought until it reaches a breaking point. This is the physiological reality of a body-focused behavioral loop. These loops define body-focused repetitive behaviors, or BFRBs. The two primary conditions within this clinical umbrella are trichotillomania, a hair-pulling disorder, and excoriation disorder, characterized by severe skin picking. The physical targets for these behaviors are highly specific. Students pulling hair typically target the scalp, eyebrows, and eyelashes. Those suffering from excoriation disorder frequently pick at the face, arms, and hands. Epidemiological data shows BFRBs affect 1 to 2% of the adolescent population, with onset most commonly occurring alongside the neurodevelopmental shifts of puberty. The visible damage results in intense psychological shame. Adolescents systematically mask the physical evidence by wearing wigs, applying heavy layers of makeup, or keeping their arms covered with long sleeves, even in severe heat. Because patients invest immense energy into concealing their symptoms, BFRBs remain dramatically underdiagnosed in school populations. The problem is widespread, but the evidence is hidden by design. The standard professional response has long relied on a severe misconception, writing off the pulling or picking as a bad habit, or a transient phase of adolescent anxiety. A behavior crosses the threshold from a habit to a clinical disorder when it is recurrent, results in tangible physical damage, and persists despite the individual's repeated conscious attempts to stop. This taxonomy tree illustrates the exact DSM-5 classification. Modern psychiatry places BFRBs firmly obsessive-compulsive and related disorders chapter. They exist as a distinct clinical category. This placement means the behavior is driven by a deep neurological compulsion to regulate sensory input. It is not an issue of willpower or discipline. When a clinician misclassifies the pathology, they prescribe the wrong intervention. Treating a diagnosed OCD-related condition with generalist counseling or advice to just stop is a critical clinical error. It leaves the underlying mechanism entirely unaddressed. When school counselors or private therapists encounter additional CBT aims to manage generalized anxiety by identifying this flowchart models a BFRB. A stimulus creates an urge, driving a motor action, causing damage and temporary relief. Standard talk therapy fails here. The unconscious sensory motor action completes before emotional triggers are processed. The intervention bounces off. Directives to simply restrict the behavior, the just stop it approach, lack any supporting data for adolescent populations. The clinical consensus is absolutely definitive. Generic therapeutic interventions simply do not work for trichotillomania or excoriation disorder. A mechanical, body-focused loop requires a protocol specifically engineered to dismantle it. The established clinical standard for treating BFRBs is habit reversal training, or HRT. HRT is a rigorous behavioral protocol built explicitly to target and break established motor sensory loops. This split-screen diagram details HRT mechanics. It begins with awareness training, where patients map micro-triggers, wedging conscious recognition into a previously unconscious process. Once paused, the therapist introduces a competing response, redirecting physical energy away from the damage site. This competing response mechanically blocks the BFARB by engaging the exact muscle groups required for pulling or picking, safely locking them into an incompatible action, like clenching fists or pressing hands flat against the thighs. Through rigorous practice and repetition, the patient habituates this new pathway, making the safe, competing response automatic when the urge arises. HRT succeeds by directly rewiring the physical behavior at the muscular level, bypassing the need to analyze the emotional state. Therapists will frequently pair HRT with a secondary evidence-based framework, comprehensive behavioral treatment, or COMP. COMP expands the target area. It assesses the precise sensory, cognitive, affective, and motor modalities that trigger the individual patient, allowing the clinician to build a highly customized defense strategy. While these behavioral protocols remain the primary line of intervention, severe presentations of the disorder often demand chemical support to make behavioral training possible. Adjunctive pharmacotherapy serves a highly specific function in the treatment matrix. SSRIs are frequently prescribed to lower the baseline of generalized anxiety. By bringing the baseline down, the severity and frequency of the BFRB triggers drop accordingly. Additionally, N-acetylcysteine, a glutamatergic agent, is well studied for its ability to directly dull the intensity of the physical urge to pull or pick. These medications act strictly as adjuncts to facilitate HRT and COM-B, not as standalone cures. Delivering this matrix of HRT, COM-B, and targeted chemical support requires specialty referral. It must be administered by a BFRB-trained therapist. For school administrators, this presents a severe logistical dilemma. You have data indicating 1 to 2% of your student body requires this exact protocol, but your on-campus counseling staff does not possess this highly niche clinical specialty. Referring these students out creates an immediate bottleneck. Specialized private practices are scarce, and waitlists are prohibitively long. MentalSpace School bridges this gap. It is a K-12 mental health support infrastructure built explicitly to integrate into Georgia schools. MentalSpace provides schools with a dedicated team of culturally competent licensed therapists. Through same-day teletherapy, they deliver specialty care directly to the student, eliminating the off-campus bottleneck. School-based clinical operations require strict adherence to privacy laws. MentalSpace operates fully within HIPAA and FERPA regulations, ensuring student data meets all legislative mandates. They're in July 2026 deadline. They also remove the financial barriers to specialty care. MentalSpace accepts major commercial providers like Blue Cross Blue Shield, Aetna, and Cigna, while offering a $0 copay structure for students utilizing Medicaid. Deploying specialized, compliant teletherapy directly into the school environment yields measurable clinical results. These metrics track the clinical efficacy of the MentalSpace system. Data shows a 92% reduction in student anxiety, an 89% improvement in attendance, and an 85% family satisfaction rate. That 92% drop in anxiety is the direct result of applying correct, evidence-based behavioral protocols to specific pathologies, rather than shame. When the physical symptoms of a BFRB are managed, the need to mask, hide, and avoid social interaction disappears. To integrate this level of clinical specialty into your district, visit mentalspaceschool.com or contact MentalSpace School at chctherapy.com to initiate a partnership. When educational systems discard the misconception of the bad habit and implement the proper clinical infrastructure, they accurately diagnose their hidden populations, treat the true pathology, and restore the student's academic potential.